My name is John, and my colleague Thomas and I are working in UPMC Hillman Cancer Centre in Waterford, Ireland, where we have 2 LNX, 2 Align RT systems, and 1 CMRT system as well. And today we'll just be sharing our experiences in implementing our Tattooless workflow. There's a title. And just a quick breakdown of our presentation. I'll just be going through the first few steps that we undertook, just that helped our move to transition into Tattooless workflow. And Thomas here will just go through some of our clinical wins, continuous development of our SGRT workflows, and some clinical case studies. So just the 3 main steps that we went through. First of which was the phase 1 super user training. This was an in-depth 2-day training back in 31st of October 2023, where we got some introduction to the Vision RT systems, patient workflows, and some of the how-tos in the system use. After the installation of the equipment, then we underwent some initial acceptance and commissioning of the system. We were following the guidelines set out by AEPM TG 147 and 302. We also went through some end-to-end testing, whereby a thorax phantom was scanned, planned, and delivered on the LINAC unit itself. And then after commissioning, then we implemented the SGRT routine daily QA. Shortly after then, our physics and RT staff completed the online training modules in the My Vision RT portal. And then on site, then the clinical app specialist visited and then went through some practical sessions with our staff. And then within the span of 3 months, we were able to go live with our SGRT at the end of January 2024. And this is just a sample of the initial acceptance tests, for example, like static and dynamic localization accuracy testing. So before our transition to Tattooless, we had to undergo a clinical audit. We kept the study objective very simple, which was to compare our SGRT setups with our tattoo setups. So the study began the 1st of February 2024, where we were using both tattoos and SGRT setups at the same time. And this went on for about 2 weeks till the 16th of February. And then after doing some data analysis and some failure modes and effects analysis as well, we were able to transition to our first Tattooless patient at CT by the 1st of March. So just going over the study, we picked over 100 treatment sessions, 39 of which were pelvis, so prostates and nodes, and 41 were free-breathing breast cases. And then other sites consisted of palliatives and abdomen cases, but we didn't use this in our analysis due to insufficient data. So we first set up our patients using tattoos, and then the plan shifts to ISOs then were made. And to get a sense of how accurate our tattoo setups were, we started the postural video feature in Align RT, and then we recorded the real-time delta values then in vert, long, and lat. And then these represents the positioning errors from our tattoos. The initial setup errors then were then corrected by SGRT using the postural video again. And then this was done prior to perform IGRT. And again, real-time delta values were recorded in the vert, long, and lat, and then these were represents the position errors from Align RT. And the post-CBCT shifts then were also recorded, and only in the translational values were used. So in total, we should have 2 sets of data, including tattoo real-time deltas with imaging shifts, and then Align RT real-time deltas with imaging shifts. And the 3D vector shifts were then calculated using the quadratic summation formula that you see here. So just a quick overview of the results. These are just the box plots for our pelvis results in the vert, lat, and long directions. So just from a qualitative visual aspect, we can see that our tattoo setups or our Align RT setups were just as accurate as our tattoo setups, with the mean and median being very close to each other. You can also see that there's a larger variability in spread of data with our tattoo setups, and these are backed up by our smaller standard deviations that we obtained with our Align-RT results. No statistical significant difference were found between the two sets of data except for the long direction. And again, when we were looking at our 3D vector shifts then, we were able to see statistical significant difference in the 3D vector shifts, where our vector shifts reduced from 1 cm to around 0.6. Again, just to bring the point again for our breast cases, for the vert, long, and lat, we were able to see much tighter spread of shifts when looking at the breast compared to our tattoo setups again. And these are backed up by our standard deviations being reduced across the board in all the translational directions. But no statistical significance again were found from these analysis. But when looking again at the 3D vector shift, as with the pelvis cases, we were able to have our 3D vector shifts from 1 to 0.5 with a p-value of less than 0.05. So just to compare our results for the breast cases, 3D vector shifts with literature, we were able to see accuracies in the same sort of range with those in literature. So comparing our results with those in literature, we were able to be same sort of pattern again, where SGRT vector shifts were much smaller. From this, our vector shifts are somewhat large compared to the literature, but this can be due to the fact that we started our audit very early on in our implementation of SGRT, and the users are starting to get more familiar with using the system. Just some of the clinical findings from this, we found that there was a good correlation between our IGRT and SGRT, and so with less distribution and less variability of the shifts, we were able to move on to Tattooless. So less patients required correctional shifts, less patients required repeat imaging as well. So as per our departmental policy, any translational shift of more than 1 cm, we would have to reset up and repeat imaging as well. With SGRT, we were able to reduce the frequency of these large shifts. So with our pelvis cases, with tattoos, we had 12 of the 39 cases with more than 1 cm shift in one of the translational direction, and this reduced to 3 for the SGRT, and then same again for breast, 14 of the 41 cases, and then reduced to 1 with SGRT. So again, bringing another advantage to the SGRT system. Some staff feedback and comment. Patients' setups meant that there was less manual handling for the staff. And we didn't do any time-saving study, but similar to Adi's sort of experience for this team, as you mentioned yesterday, although not as drastic, we were able to save 5 minutes for our DIBH treatment cases, and which is sort of a clinical win, which now Thomas will go through.
So I'm just going to spend the next couple of minutes going through, I suppose, the more practical applications associated with our Tattooless workflow. But firstly, just to mention a couple of our clinical wins. So we've had a safer delivery of treatment, so whether that's the patient benefiting from constant interfracture motion management, where we can critically assess their position in relation to the image that was taken, or the staff benefiting from the reported reduction in manual manipulation of patients. We have a reduction in the rates of reset up and re-imaging. Again, this is an inference based on the audit results that John mentioned, where we were applying fewer shifts greater than 1 centimetre when setting up using Align-RT. And we've also had an increase in time efficiency. So clinically, we were able to reduce our 2 field DIBH appointment times from 20 minutes to 15 minutes, which is a time saving of about 50 minutes to 2 hours a week, depending on patient volume. So a massive, I suppose, time-saving aspect associated with setting up using Align-RT. In relation to what I'm going to be discussing for the remainder of the presentation, I'll be discussing our ROI optimization process, a little bit about breast DIBH troubleshooting, and then just an extremity case study to round things off. In terms of ROI optimization, I think we can all agree that the ROI is the most fundamental aspect to any setup using SGRT, and this takes even more importance when we are considering setups without tattoos. So we had developed a competency-based training program for all of our new users, and it works in conjunction with this ROI work instruction as part of our SGRT policy. And it just, I suppose, gives new users a good understanding of the system, so they know what we want to achieve, how we want to achieve it, and most importantly, when to action and troubleshoot effectively. So by giving new users examples of good ROIs and bad ROIs, it provides them with the means to troubleshoot effectively on set. An example of this that we've had recently was a gentleman that, a pelvis patient, setting up using the standard pelvis ROI. However, we were noticing gross longitudinal shifts, so shifts that were approaching 1 centimetre every day. So after careful review of the plan and looking at the postural video in relation to the real-time deltas, what we noticed was we needed some more SUP-INF information, so we decided to add the umbilicus strip to the pelvis ROI. And what it resulted in was a mean decrease in the longitudinal shift by about 0.7 centimetres. So something that was previously gross was now within our departmental action level. So a huge improvement in accuracy there. And I suppose the taking here isn't to amend your standard pelvis ROIs to add this umbilicus strip, but the taking is to just, I suppose, recognise an action in an underperforming ROI. This is the results that you can yield. In terms of learnings and recommendations, a robust training program is essential for the successful implementation of Tattooless workflows. Recognising underperforming ROIs and problem solving effectively leads to consistently accurate setups, and ensuring all users have a good understanding of the Align RT system. So just, I suppose, knowing that we're always trying to establish the relationship between ROIs and real-time deltas, and how this kind of relates to the body contour and the postural video. In terms of breast DIBH troubleshooting, just to run through a specific patient example that we had a left chest wall AD for treatment, scanned and breath hold using SIM-RT. Standard workflow used the respiratory patch placed centrally on the thorax, and we got about a 0.9 millimetre amplitude increase. However, when we were importing the scans, what we noticed was there was a minimal contour difference between the free breathing and breath hold scans, which we flagged for a cause for concern because Align RT uses body contour difference to establish the amplitude. So we carried out a free breathing planning exercise, but there was no luck. We had to plan in the breath hold for optimal PTV coverage and OAR constraints. So I suppose our initial thought was just to set this patient up standardly using Align RT with the visual coach. However, just as we expected, the amplitude was only about 0.2 or 0.3 on the vert RTD, so we were seeing a big deviation in the heart position and the diaphragm position, so not relative to what we planned at all. So our solution was really simple. We just decided to remove the visual aid for this patient. What it did was it kind of removed that, I suppose, the pseudo amplitude, trying to meet this fake amplitude, and allowed her to breathe in that little bit more relative to what we planned. So just something really simple that you can use to ensure accuracy when delivering treatments to all patients with different anatomical topography, I suppose. Another problem that we encountered quite frequently when treating left chest wall patients, particularly in DIBH when centering the couch for cone beams. When we centred the couch, what we noticed was the ROI was jumping up towards the face and across the thorax, which is typically okay in a free breathing situation, but because we needed to maintain the DIBH amplitude throughout the imaging procedure, once the ROI jumped, we completely lost our amplitude information. So what we decided to do was draw the ROI on the contralateral breast and use that as a positional surrogate for setup, and then also something that gave the cameras enough information to, I suppose, fuse the ROI onto the reference capture and maintain a consistent breath hold throughout the imaging procedure. I would note, however, we would only ever do this on a case-by-case basis, and only when we noticed significant variation in the vert RTDs from our starting amplitude. So the learnings and recommendations for this is to consider contour change direction when deciding on coaching methods, so whether you want an audio coaching or a visual coaching. Obviously, the patient ability would be a factor there as well. Consideration of contralateral ROIs to achieve and maintain breath hold when, for chest wall patients when centering the couch for cone beams or something that might cause your ROI to jump and lose the amplitude information. And then just to make sure you're always noting your starting amplitude, so your vert RTDs when beginning any breath hold procedure, just to make sure that you're maintaining a consistent breath across the imaging and treatment procedure, especially in the absence of a baseline. And then just a quick extremity case study to round things off. We had a left forearm gentleman needing treatment. More towards the beginning of our Tattooless journey, we didn't have much experience of treating extremities at that point. So we simmed this gentleman as normal in a vac bag built up around the arm for optimal position and immobilization, and placed bolus.CT. However, this time we had no anterior alignment tattoo. So when this gentleman came for treatment, we ran into a number of problems. The first one was that there was a field of view limitation of the cameras, so it didn't have enough body contour to set up to. We couldn't place an appropriate ROI appropriate to the treatment site because of the bolus and the lack of body contour. And we also didn't have much anatomical information in the postural video tool because it was blocked by the contour of the vac bag. So this is the setup that we had achieved. There was loads of rotations, so the rotations were big, the translation were just as big to account for it, and we couldn't place the bolus as planned. So we decided to send this gentleman back for a rescan, and after much deliberation, just decided to go with something really simple. So the arm slightly akimbo, flat on the tabletop. However, we did still scan with bolus, but this time we could take advantage of an ongoing quality improvement project that we were doing, where we were cropping the bolus off the body contour so that we could create a skin setup surface which allowed us to place an appropriate ROI applicable to the treatment site and get a good positional anatomy prior to bolus placement. So we did just that. This is the body contour that we utilised for that patient then. So the ROI was good. We had RTDs that were representative of the treatment position. We had an appropriate amount of anatomical landmarks in the postural video tool to correctly set up the arm, and because of that we could place the bolus as planned. So you can see by the image that the translations are very small, rotations are minimal, and the bolus is exactly as planned. So a good outcome for that gentleman. And then in terms of learning and recommendations for extremities, we have decided that to go with simplistic setups at CT Sim for more reproducible and consistent setups when using Align RT Advance. So that obviously is a reduction in resource intensity as well, so you don't have to make vac bags. So there's a benefit there as well. The postural video tool is paramount to ensure rotational accuracy, especially in the absence of an anterior alignment tattoo. And finally, creating a skin setup surface ensures delta shift values represent bony anatomy prior to bolus placement. And that is all.